and it'll tell you.
All right, welcome everyone to the June 16th, 2022 Flathead City County Board of Health meeting. We have a fairly full agenda today with a variety of staff and department reports. And so with that, we'll get going. First thing is, can you do a roll call attendance for us, please?
Sorry, yes, I'm not sure. Do I do?
Just read everybody's name and we'll say here.
Okay, Artis. Here. Rod.
Here.
Ronnalee.
Here.
Dawn.
Here.
Jess.
Here.
Pete.
Here.
Roger.
Roger. Oh, you're sorry.
Pam will be in and out today. She's got some commitments that she will pop in and out as her availability allows. So pretty much
Does that make her an attendant or not?
Just when she shows up. All right, first item on the agenda is the approval of the agenda. Any modifications?
I think we move that we have an action item regarding the future status of the home health. I had intended for that to be included in here based on the committee recommendations.
So there is home health operations committee report.
But there's an action that needs to go before the entire board.
So we will add that in at that time.
Okay.
All right.
Motion to accept the agenda.
Second.
Okay, so there's a motion and a second to accept the agenda as modified. All those in favor say aye.
Aye.
Any opposed? Motion passes. All right, with that, the next item on our agenda is the public comment. We did receive some written comment. With that, we start with verbal comments from the audience. Is there anyone in the audience that would like to provide any public comment? I don't see anybody raising their hand very fast or coming to the podium. I will take it. They're all just punching out. Does not appear there's any public comment from the immediate audience. Janelle, is there anyone on? If there's somebody on the Zoom that wants to provide public comment, please raise your hand and Janelle will release you to speak.
The ones who signed up said that they did not want to.
All right, with that, there does not appear anyone on virtual Zoom meeting that wants to provide public comment, so there is none. With that, we will move on to the approval of the minutes from the last board meeting of May 19, 2022. Is there anybody have any comments, modifications, revisions, exceptions?
Make a motion to.
All right,
Second.
okay, any discussion? Okay, it's been moved and seconded to accept the minutes as provided in our packet for the May 19, 2022 meeting. All those in favor say aye.
Aye.
Carries. All right, with that, we have our first action item on the agenda. Joe, give us an update on the regulations.
Thanks, Roger. So right at this moment, coming out of our environmental health committee meeting, we made some decisions on. We're working on some appeals of the health officer's decision, and it was considered at the environmental health committee meeting that we really ought to look at our regulation. And our regulation in section 10.2 does not allow variances to certain setbacks, both groundwater, bedrock, physical limiting conditions. The board committee's belief that we have several of these in the pipeline, and we already had a variance 2 months ago regarding this. Instead of continuing to hear these appeals of the health officer's decision, but technically it's an issue of operation of the regulation, which can be a variance in and of itself, and I hate to talk like that because it sounds like I'm talking in circles. But it's best just to change section 10.2 and allow variances to be heard for new construction to the setback up to groundwater. You're going to hear them anyway, or we're going to say no, and they're going to go to DEQ, and they're going to use a very narrow format, and they're going to be approved. Because all of these can show that they don't degrade water quality. So DEQ would only look at that narrow focus on water quality. They would approve the variance, they would send it back to us, and we would issue them. I think it'd be best, I think we all felt it would be best if we heard the variance and set the conditions locally, and we didn't just get this back from DEQ to issue it. So that's that part. Section 8 of the regulations, we neglected two other types of septic system formats that could be done by a designer, and so they do that. So it's a slight modification to section 10.2 and a slight addition to section 8. Just to remember, with House Bill 121, you will recommend this to be moved forward to the commissioners for action. So this initiation of rulemaking will go to the commissioners. I have a placeholder for next Tuesday for this. I'd like to kind of get this done before I leave. And so I have a placeholder for next Tuesday, and at some point I would ask that you hold a special board meeting to do the public hearing. But we can talk about that after, if you want to move this forward.
Does anyone have any questions or comments for Joe on this item? Well, I thought that meeting, one of the things we was talking about was doing away with just the wording, new construction. Right. So that's one of the parts, and then you've gone back to the town.
Just to kind of minor definition on who can design septic systems, and or because right now with them not in there, they could only be designed by an engineer, and these systems don't need to be designed by an engineer. So, and they don't have time to do these.
And just to reiterate what I heard you say is that you feel that this rule, and it's the committee's opinion, that this rule change would actually lead to a more substantial oversight of the variance review than should we not make this change and these get kicked to the state. Is that that's the committee's feeling on this?
We have the ability to put conditions on that are more enhancing than just meeting the non-deck criteria. Almost every variance that we push out of here with conditions have level 2 treatment on. And so we're automatically requiring a higher level of treatment than just meeting non-deck. And I think that's why we really should not allow DEQ to make these decisions for us. And the other thing I've mentioned is I polled other county health departments, none of them have this criteria. This is not a criteria that's a tag along from the state rules. We put this in years ago. No other county has this criteria.
So, and if you'll recall, about 3 or 4 months ago, we did update the rules and we went through that rulemaking process. And this actually came up during the rulemaking process, and Hardis brought it up and thought we should remove it at that time, but then we were kind of hesitant, and now it's become more apparent that if we should just get rid of that new term, so because there's going to be a lot of these in the pipeline. And the other thing is, the way it is now, if we can do that, then we don't do that, as Joe mentioned, it gets sent to DEQ here. And so then that's just gonna take a lot longer for anybody to get a permit, whereas we can process it here internally and expedite the review and processing and approvals of it. So we, for those reasons, we think it's a good move.
Just to clarify, there are a lot of variances coming through us that will require their, like a variance to the setback to groundwater, bedrock or impervious layers. So a lot of new construction that wants to put a septic in that's too close to, like, it's these 3 requirements. And so then we're gonna approve those. Plan.
Just what, most of these are old lots that have never been developed.
Okay.
They went in before 1993. 1993 is a magic number for the state of Montana. That's when they put the non-degradable law into effect. We do have a lot of older subdivision lots that still haven't been developed. And just a handful that we may have not caught this and approved it. Puts us in almost a taking position of the property, which is a real big issue in Montana. But we don't want to end up in a takings because we approved something at one time and then have not allowed it to be developed now.
So the variances that are coming through, when we make this change, they still come before some environmental committee still reviews them. Okay. And then I guess my question would be, like, we're in a very transitory type period where we're going to get a new health officer, and if things change on the Board of Health and we don't have as many people with like really strong backgrounds in environmental health, what would happen? I guess kind of that's my concern. Like, what happens if we just start, like, if the variances aren't as well vetted as they're being now? Is that a possibility that in the future?
Well, I think, we have a variance policy, and the staff themselves are the ones that review it and catch it and then bring it to the committee for review. So it's really the staff's responsibility to start the process. And then forward it on to the reporting.
And then we approve it. So that's kind of my concern in the future. I just want to be sure that we don't get too out of the, like, I really have a lot of faith in this Board of Health, and I appreciate everything that everyone does, but just thinking, like, in the future, if we don't have a lot of people that have such strong environmental health backgrounds, what happens if they're responsible for approving things that have been denied by the health officer? So that's kind of just trying to think, like, if we make this change, will it in the future hurt us ever, or do you think?
Well, Dawn has volunteered to be on the board for perpetuity.
Okay, perfect. Well, then,
No, good point. There will always be at least 1 or 2 members on the board that are environmental health related.
Okay.
So I think that's just kind of the makeup of the board. So
Yeah.
I don't foresee that.
Actually kept in mind, good.
maybe add it to the.
Yeah. Okay, with that, any other discussion, questions? All right.
One, Roger, please. So all of the variances that we've seen in the past, are they on that magic date? Is that the trigger for most of those? No. So there are others besides just, they were approved, but now aren't. There are others as well that fall into this.
There are many of our variances have to do with hydro. There are a lot of hydro water. And a lot of them are for replacement of old systems, right? That's, we hear a lot of those. It was our intention years ago, we put in the deviation, but we were adamant that deviations by the health officer would never be made for water, groundwater or surface water. And I was the one that was a real big proponent of that when we put deviations in our regs, just like we can. And with that, I think Pam might be the only one with that. But I was really an advocate to keep this in the boards. It's really important because you can place, you have the you have the ability to place conditions upon things that staff does not. And I'm just a staff person. Well, we do hear a lot of groundwater, so you'll always remember that, but oftentimes it's for replacement of drainage systems.
Thank you.
Okay, so with that, if we need a motion to move forward with this action item.
I'll make a motion to move forward with this action item to the county commissioners.
Thank you.
Second.
All right, it's been moved and seconded to forward the rulemaking onto the Flathead County Commissioners. Any further discussion? Okay, let's, Janelle, could we do a roll call vote, please?
Yes. Artis,
Yes.
Dawn,
Yes.
Jessica, Pam, Pete,
Yes.
Rod,
Yes.
Roger,
Yes.
Ronaldie.
Yes.
Thank you. All right, we will move on to department reports. The first one is Cliff with the animal shelter.
Afternoon, Mr. Chairman, members of the board. I don't have a lot to, luckily for you, to report today. We're having a lot of dog turn-ins right now, people moving and, you know, the housing difficulties and that sort of thing. So we're dealing with that. But we'll get through that. The construction of the new building's about complete. We should be in there before the end of this next month. And so if you have time, come by. It's pretty exciting. And the staff of the shelter wishes Joe well. And thanks for everything that has been done on his behalf for a shelter that we're all proud of. Excuse me. So, any questions?
Thank you, Cliff. All right, community health.
Everyone. I also don't have a lot to update you guys on. Just a couple things. So since our last chat about our Montana Asthma Control Program, Rebecca's caseload has continued to blow up. In May, she was 12 out of the 15 required number, with 6 more scheduled to add in June and 5 on her wait list. So she is doing fantastic in that program right now. Our maternal child health safe sleep initiative just received some pretty high praise and kudos from the director at the state level. We're inquiring more details to add to their application for the next round of MCH funds from the feds, which was fun to be involved in. We did have an MCH nurse sign an offer letter this morning, which is awesome because that position has been vacant for quite a while. So I am extremely excited about that. Home visiting caseload is almost completely full, and it increases to 77 here for June after the commissioners gave the okay to receive the extra funding for that. Immunizations is just really focusing on their quality improvement project right now for HPV and doing education and a strong vaccine recommendation for our HPV vaccine. And then WIC is focusing on the farmers market program, which is starting, and we have a schedule to attend some of those farmers markets to do some outreach and networking with the farmers and getting more participants over there. Any questions?
Very good, thank you. Okay, population health. Lisa.
All right, good afternoon. I know it's been a long time since I presented or reported during the Board of Health report. So for those that might not know, I'm Lisa Dennison, Emergency Preparedness and Communicable Disease Coordinator within Population Health. So you get me today, Jen is out. So just looking at the communicable disease report there, not too much as far as outliers go. We did have an uptick in our Seminole cases within the last month or two. Interestingly enough, we didn't really find too much commonalities with these cases, although there were a few that were associated or had some exposure to live poultry. And actually, one of those cases was linked to a multi-site outbreak related to live poultry as well. So, and then regarding influenza, last week was officially the last week that we reported influenza cases to the state. And our running total for those cases was about a little over 600 cases to the start of the season, which obviously not everybody goes to the healthcare provider for influenza or symptoms they have, so obviously that number is probably underreported. But in comparison to previous years, that's depending on the years past, it's been about 30 to 60% less than what we've had in other years. And about 98% of those cases that we had were reported in influenza A. And then on a staffing note within our communicable disease program, we have Jim Wardinsky over here. So he's acting as our long-term care facility, congregate care facility specialist. And he has recently taken on a position within the health department, a new position as an environmental health manager. I'm sure Jill can speak to that a little bit more. So we'll be looking to fill that position, but we're sad to see Jim leave our area, but we're super excited to see him move into that area. We know he is going to do a phenomenal job. We're just happy to see that he can continue to be within the health department umbrella. On other population health related notes, Malia Friedman, our epidemiologist, is also trained as a public information officer. So she was deployed to help with Brian Eno's incident command team for the flood response. So she's been working with them and doing an excellent job on communicating information out to the community. She also has recently updated a lot of the health department's flood related education materials and brochures specific to what to do and prepare your septic and well for flood. And then once the flood water starts to recede, how to disinfect your well and also other flood related information. So that is on our website and also updated materials. Those updated materials were provided to environmental health for them to disseminate to the public as needed. And lastly, sorry, I feel like I'm filibustering up here. Car seat safety stuff. So Wendy Olson reported on to us that a 2-day enrichment training was provided in Kalispell, focused on child seat safety for kiddos who have special health care needs and knowing how to receive the training on how to restrain those kids, children appropriately. And that training hasn't been provided in Montana for over 15 years, so it was a great training to bring into Montana. We had 2 of our health department staff that participated in that training. One of them being Wendy Olson, our health nutrition specialist, and another was a home visitor within our home visiting program. So it's great to have that extra level of experience and training for those to provide those services to the community. Otherwise, that's all I have, unless anybody has any questions.
Great job on getting that hit of the curve on the flood response.
Oh my gosh.
Wonderful.
Thank you.
Okay, on to family planning.
Good afternoon, everybody. So family planning's numbers are staying above average. We like to see them above 200, and we hit that goal this month and continue to see patients accessing care. I wanted to let you guys know about how we're integrating technology into our practice. Last month, I talked about our online scheduling. This month, I wanted to let you know about our online bill pay. We implemented that program about 2 months ago, so patients can receive a text or an email letting them know that they have a balance in our clinic. They can click that link and easily pay their balance. Within the past 2 months, we have received over $4,000 of patients from about 40 individuals, which is really great because typically we see when you have an outstanding balance, if you're not paying in person at the clinic, we don't typically see patients coming back and paying them. So excited to continue to watch this process and monitor RAR to see how those efforts are affecting RAR. Our month of May was really busy for outreach and education. Our health educator, Andy, reached over 900 individuals, mostly at freshman health classes, talking about reproductive health, pregnancy prevention, and STI prevention. So still doing a good job meeting the needs of the community and providing our education. We continue to do syringe exchange. You might have noticed that we've taken a little bit of a dip since April with monthly visits. Around April, the staff member that was operating syringe exchange program left her position. So myself and the health educator has been covering it. And when you're working with this high-risk population, it does take some time to build trust with them. So we have seen a dip in visits. Then as we continue to build that trust with these participants and hire someone, we hope to see those numbers increase. We anticipate having a staff member fill that position August 1st. And then lastly, tomorrow I'm going to be attending a Master Narcan training program where you can learn how to, one, administer Narcan, but then become a master trainer where I can go to other social service agencies and teach them how to respond if they come across someone who may be experiencing an opioid overdose, how to administer Narcan and how to use Narcan. So just another community resource the health department can deploy in the community. That'll be tomorrow. Any questions?
What percentage of patients, just like Gestalt from the syringe exchange program, do you think will walk out with with some Narcan?
Walk out with Narcan?
Yeah.
I would say 90%. We offer it at every face-to-face visit.
So you think 9 out of 10 times?
Yeah, they
Great.
are asking for it during most encounters, and then it's also available in our vending machine for free for anyone who doesn't come up to the syringe exchange program. Other questions? Okay, thanks so much.
Thank you. All right, Jay. Mosquito report.
Good afternoon. So obviously there's a little bit of water out there. We're pretty busy. Have great staff and everybody's working very hard to do what we can do, but unfortunately there are a lot of areas we simply can't access. So would like to remind everyone, mosquitoes are most active at dawn and dusk. Wear long sleeves and pants and wear your repellent. There will be mosquitoes this summer, I'm sorry to say. We are focusing on the areas that typically are Culex habitats, and with flooding outside of normal river channels into kind of flat grass areas that are prime habitats for Culex mosquitoes, we anticipate quite a bit of activity in the following weeks. So we'll be monitoring those really closely and trying to get those to hard. On another staffing note, I just want to say I will be moving into a sanitarian position here in environmental health, slated to start July 1. Hopefully the weather cooperates with that. But just wanted to introduce Brock Bull. He's been in the mosquito program since 2018 and he's going to be taking over. And he's the hardest working, most dedicated person I know. So the program's in good hands. Any questions?
So obviously you're inundated.
Yes.
No pun intended, but how are you going to prioritize areas to apply?
We are focusing on right now with floodwater mosquitoes, areas that affect the highest populated areas. We are very active in Evergreen, Columbia Falls. Summers hasn't filled quite yet. The lake has come up, but we still have some time there. Ferndale is another area that we're hitting quite a bit. Along the Whitefish and Stillwater rivers, heading north to, and obviously the lower valley area. Especially with all the new subdivisions there, we're focusing on that. We are using the drone extensively to hit areas we can't access and have been seeing good results with big treatments there. As the floodwater mosquito hatch starts to subside a little bit and we move into the Culex season, we will be focusing on areas that we know produce Culex and areas where it has flooded pastures and hay fields and things like that that we know are going to be hotspots for Culex.
Congratulations on your lateral move. Whatever. So, we're up. All right.
Well, thank you.
And likewise to you, gentlemen. Great. Okay, I guess on to environmental health.
Roger, before we get started, Jim, you want to come up? I'm going to put Jim on the spot a bit, but we, as Lisa mentioned, Jim comes to us with an extensive law enforcement background and brand new masters in criminal justice. Now I'm making him embarrassed. I've enjoyed working with him so far. He's a great, he learns very fast. He's picking up a lot of this. He has a lot of good leadership skills, which will very help us in environment. So with that, Jim, why don't you fill in the blanks?
Thank you. As Mr. Russell said, I recently retired from the Kalispell Police Department. I spent 24 years there with them. During my career, I was very fortunate to have a lot of opportunities with them. Everything from patrol to school resource officer, drug team, detectives, was a patrol sergeant, detective sergeant, was the investigative captain, and finished out my career as the administrative captain there. So, you know, from a leadership standpoint, I feel pretty comfortable assuming the role where we're in environmental health. Obviously, from the science aspect of it, I have a lot to learn, and you know, hopefully the staff over there will be gracious enough to help me through that stuff. I do have a little bit of a glimpse of some of the stuff that they do over there. Prior to becoming a police officer, I was a plumber for 8 years, 6 of which were in the military and 2 in the civilian world. So, you know, I do have some understanding with the septic and sewage stuff and water distribution systems. I think too that some of the other transferable skills that I bring to environmental health are, I have a strong investigative background. So I was fortunate enough to be able to tag along with Danielle, one of the sanitarians over there, on a food inspection here at a local restaurant. And one of the things that I realized, I guess, as we were doing the food inspection is that, you know, the attention to detail, the ability to document things is critical in those roles and all that. So my master's degree, although it's in criminal justice, there's an emphasis on executive management and leadership. So, and it was primarily focused on dealing with public entities. So there's a lot of budgeting, HR stuff, and strategic planning, things like that. So again, I think that those skills and that job knowledge are useful. I'm very appreciative for the opportunity, and I'm super happy to be here at the health department. You know, one of the things that I expressed to Lisa, my boss, is that when you leave a role like I did in public safety after 24 years of being there, you really wonder, was that the pinnacle of my work life? You know, am I ever gonna encounter another work environment where I'm challenged and I feel that it's really a righteous cause to engage in? And I think I found that here at the health department. You know, there are a lot of fabulous people. They're very encouraging and kind and technically competent and all that. So I've been super impressed in a short time. I can answer any questions if you want.
Well, just to add, Jim will keep doing our rabies stuff. And he'll be across there. Our FT group is going to actually move to elections second week in July. And that'll be good because they can have the dead skunks on that side and not destroy our building for 2 days. Sorry about that. Yeah, we started out with a cute little dead fox the night before, which was just fine. But when Jim brought the skunk in, everyone's going, who's smoking that one?
Sorry.
No, it's actually public health and science. That's what we do, right? That's what we do.
Right, welcome aboard.
Just report wise, very similar. 90 applications received last month, 59 inspected. That number will continue to pick up. The applications should go down until we get, oh no, it's going to be much of it. But very similar. The food programs just churning along a little bit above regular activity. I know we're going to have some low scores come up next month because I just signed one this morning. Any questions on the report?
All right, I guess we will move on to the current finance.
Good afternoon. This is the finance report for May. Budget-wise, we've got on June 28th, the county commissioners will review and adopt a preliminary fiscal year 23 budget. And I'll be working on next couple of weeks and the close of the fiscal year for the health department. So general fund cash balance the end of May was 1.9 million compared to 1.5 million a year ago. So good shape. We collected about $500,000 in tax revenues for the month of May. So that contributed obviously to that balance there. So again, general fund in good shape. Home health. Home health May cash balance was a negative 135,000. As of today, negative 152,000. So dropping off, the total cash and net accounts receivable at the end of May was $104,000. And that's been slipping also. So we had a home health meeting where we met. At the home health meeting, I was able to discuss some of the negative trending financials and statistics that are happening over time with the home health financials. So that's it for me. Any questions about any reports or?
All right, thanks for the appreciate it. We'll move on to Jill.
Yeah.
You know, a lot of the stuff that came into what we discussed in our and what we discussed in the committee reports. You know, we're seeing some increase in our case numbers. We've seen the numbers before. Hospitalization, the nice thing is even though the prevalence of disease has gone up, our hospitalization rates are still moving manageable. And I think that has a lot to do with the mild nature of Omicron and the subvariants associated with it. As Jess mentioned earlier, I just don't know if the vaccine lines up well enough to keep the breakthrough cases, which I did not report. Breakthrough cases are averaging 70 to 80% of the cases, and tells you a couple things, right? That the vaccinated population is getting it, and it's pretty much not, we're not going to be able to stop some of this transmission, but it is becoming a mild disease. Questions on COVID?
So saying that they don't line up very well. So does that mean that getting additional jobs boosters is something that should still be considered?
I think that has a lot to do with where you are with either comorbidities. You know, if you have some underlying medical conditions that might lead to a comorbidity with it, tag on if you want. I think that a lot of docs are recommending it if you're obese, if you have some of these other underlying medical conditions. I think that the prediction they made at the beginning of the whole vaccine campaign is the vaccine can lessen the severity of the disease. And I think we're still seeing that. I just don't think it aligns well enough to stop transmission of the disease. And that's just reflective of what I see in the numbers on a daily basis.
Yeah, I mean, and if you look at the CDC's recommendations, even currently, they changed the wording. They on the first booster, they pretty much say everybody 12 and older should get a booster. And then their reading on the second booster is they may or they can consider getting a second booster. So the evidence for the protection of doing subsequent boosters is not as strong. So you see even the different wording with that. And then you wonder, and I think there's a general feeling that it's somewhere coming down here that they'll probably change the genetic sequence of the vaccine in subsequent rounds. So I think there is a potentially short-lived benefit to a second booster. I've been telling my patients, like, for example, if you have significant comorbidities, or I think people who are maybe traveling to really population dense areas where they're going to be around a lot of people and increasing their exposures, you kind of got this. I think there's still a little bit of a silver bullet phenomenon where you can get a short-lived bump in your immunity that's still probably worthwhile if you're traveling to, again, more population dense area, or you're planning on doing something where you're going to be around a whole lot of other people. Yeah, that's my understanding of things.
This slide that you've been seeing in your situation reports, we're the last major population county that still is low, and we are bouncing barely into medium and back into low. But Gallatin, all of the other counties are in the high and medium. So I don't know what we're doing here in Flat County, probably underperforming where the others are. But Lisa's going to be doing the situation report the next few days, and she wore the right color because I'm thinking we're very close to going into medium. But
I think people are under testing.
Well, significantly. Yeah, it's at least 3 times. You know, if it was 2.8 during some of the other variants, with a milder illness, we're seeing a lot under.
Well, I mean, and some extent that makes a little bit of sense too. Like, there's a lot of responsible people who school was in session, and they said, I'm going to test my kid and make sure that they're negative, because I obviously want to be a responsible parent and not want to send my kid to school if they're COVID positive. And then now it's more like, okay, well, if we've got symptoms, we're just going to kind of stay home and stay away from people regardless. So I think that there are people who are just choosing to self-quarantine without necessarily getting tested.
Or you have like at home test.
Or you do an at-home test, right? Exactly. And that doesn't.
I mean, like I tell people, when I was positive for COVID, I just told people
We were on record, Jess, so we all know
I have said that I was positive for COVID last week.
we'll get you in the box.
Because really now, one of the main incentives to having a documented in clinic test is if you're going to get Paxlovid or something like that, then we typically are going to ask. We're going to want to verify your positivity before writing for Paxlovid or something like that. So those are still scenarios where people are going to be wanting that confirmed test in a clinic that's going to be reported.
Right, Aaron.
Well, just heads up, we will try to schedule a special board meeting to the public community. I think Janelle will send something around. What were we thinking? So either next Thursday or the following week. We'll send an email out to see what we can do. And quite frankly, we do it late and we'll open it up for Zoom. We could do that. I'd like to get the public hearing done.
Yeah, be great. Okay, and with that, we will move on to the Home Health Operations Committee.
We have the links from the,
If you refresh, it should be on that. Mine's just running slow, sorry.
so I think some of these graphs down in the middle of the attachments are really what kind of paint the picture. So, I mean, I've been on the board for about 2 years now. And even since the time that I came on, the board, the home health has been, despite everybody's best efforts, been in this situation of trying to right this ship of being financially responsible and being able to deliver the care that patients need, but also to remain economically viable. And the concern, obviously, being over the past several years that the quality of care has been met, and we've been supplying good care, but we have not been able to do it in a way that that we've been able to remain neutral from a financial standpoint. And we've had several meetings, brainstorming ways, discussions about how we can potentially change that over the course of the past few years, as far as trying to improve our payment, trying to improve our percentage of referrals, cost savings measures, all of those things, and certainly certainly with all of the best intentions to do so by the staff at the home that works in home health, Cheryl and team and everybody there. But it's been clear, I think for some time now, that the trend continues in the negative direction as far as the fiscal responsibility of the home health organization. And given the current environment, it is the feeling, it was the recommendation from the home health committee to bring in front of the whole board and the commissioners that we actually, in brief, get out of the home health business, and that we wind down the home health department and the home health operations as part of the county health department. And I think it was something that we certainly wanted to see work, and I think, and again, not at all for a slight anything that's been a lack of effort or a mismanagement or anything like that. It just, in the current environment, given payer mix and reimbursement and healthcare models in the valley and in the system, it just is not. It's a situation in which the health department should be operating the home healthcare system. So you can see the numbers in front of you. I think if you have questions about the specific numbers, maybe I'll defer to Kirk on some of those if any of you have questions about numbers. But then the recommendation of coming before the board for an action item then is to wind down services for questions.
What's the plan for people that are receiving services transfer care?
So so in the so if we agree that if the board agrees with and the commissioners with winding down home health, then we can make the wind down process look. Will certainly be done in a responsible manner by the staff, and that would probably, I would imagine that would look something like no new referrals, but continue to care for people currently enrolled until for the next couple of months as their rehab time has been allotted for or approved for, but then would not be taking new referrals going forward. And in the situation, if somebody, again, most people don't have prolonged things. If there's something prolonged, then would likely be referred over to the other home health agency in the valley. But I would imagine that the wind down process would include completion of care for those currently enrolled.
Just to add, Roger, the committee directed Kirk and I to meet with Cheryl, which we did last week. Gave her a heads up of what was going on. Most episodes are 30 days and some are 60. We're putting heads up, no new admissions, and at least by a 60-day process, we'll take readmissions. I mean, we're not going to sever this program. We can wind it down in such a fashion that will reduce our labor costs, reduce our expenses as we go. And I think if we still believe that if we capture the AR, we'll actually end up not losing money. But we're right at that point, whereas if we continue to operate the AR, the accounts receivable might not cover our deficit. A couple other things that I found out today, I just relayed to Pete before the meeting, is this is not a certificate of need anymore. The license does not have much value. The business has value, but the license has very little value. Wouldn't be worth it for us to try to sell it, but we could reassign it to another agency if they want to do it. And it might expedite the process of establishing another home health program in Flathead County. These are all things that we'll explore. I was on the phone with the program manager at the State Department of Public Health and Human Services before this meeting. So just talk to her a little bit about it. We have a little work to be able to wind this thing down, but we're not going to take people off of service. We will stay in service. And the sad thing is, the most ironic thing is, I got a call from Ann Ashley, who used to be the board chair, who is on home health, our home health service right now, and just wanted to call and say how wonderful it's been. So the irony of closing it down when we get a call from the previous board chair saying how wonderful the program is kind of like, just take a little fork and jam it in your way. But as Pete said, this is just not the way to operate this license. You either have to be bigger and stronger, or you have to be smaller and more. And we're neither. Now, I hate to say that. You would think that we would be able to figure out a better way to do it, but I think our contract costs and just the other things that really push against this, the fact that we do see a really high acuity patient, usually they need a lot of care, and our agency has always wanted to give the utmost in care, and the fact that we sometimes get the low payers, and I think that has a lot to do with being a county program. It's just the numbers just don't work. They've been not working for a long time.
And they even had a temporary life injection from some other COVID funds that kind of kept things level-ish for a little while, but the overall regression line is still as it is.
So why is it so difficult to make these collections? I guess is my question I have.
Part of the collections are always take a period of time to collect. There is such a large time lag, and it's really not the collections that are hurting the cash flow. There's been periodic expenses that have reduced the cash balance. And over time, this isn't, we've been in a downtrending. I can't see the date there. But just in November of 20, I mean, you see, overall the trend, probably shrink that a little bit. But long story short, the accounts receivable isn't the issue. It's just the model of the business that is the issue. That can't be improved upon in the current condition. If that makes any sense. Eventually, we will be collecting EAR, and if you notice in the financial reports, we do take a haircut on the AR just for bad debt. So make sure that we keep our AR conservative, and then over time, obviously, we expect to collect the remaining amount. But if we did collect that cash flow, that would help our cash balance. But it's really the revenue line that needs to be increased, and the expenses to be minimized a little bit to put us more in a profitable position.
Any other questions for Kurt or Dr. Aylward? Thanks, guys.
So I guess this is an action item to.
All right, so then the recommendation to bring before the full board then is the committee recommends and submits to the board a motion to wind down community health services as part of the home health services as part of the health department. That would be the motion on the floor.
That's in the form.
Sorry, I'll second.
Just wondered if that's in the form.
So what's the wind down period, do you think?
I think
The August.
end of 3 months.
Give them the license. Seems like it would be, somebody would be interested in that license. We should try to make that available somehow, that so that if somebody else wants to pick it up, because I understand there's only 2 licenses in the county.
But Roger, it's not a certificate anymore. Anyone can apply. But we could reassign that license. The only thing that's CON now is long-term care hospital, some hospital activities. We could reassign it probably easier than they could apply. And we're going to attempt to do that. I have some thoughts in mind.
Okay, so it's been moved and seconded to